surveys. So it's now 1 p.m. on my time, and we are now starting the webinar. We are starting the recording, so you are all welcome, new attendees, returning attendees, but also the scholars who are doing the course actually. So I'm here today with Jan Gravendon and Carolina de Navarro from WHO, but also with Heather from CDC. They will be the subject expert for today's topic is data use, and we're really happy to have you. So we'll start by going through the tools that we will be using. I'm talking about Zoom. You will have to interact with as some of you know how to do, is the chat box. The chat box is where you can type your comment, and you can even type the country and the town you are connecting from and say hello to everyone using the chat box. Please make sure that you turn to attendees and all participants. But also we have the Q&A where you expect to write your question there or vote to the question that you would like to see answered. So I will now ask Jan to help me by moving the slide forward so that we see together what are the ground rules, and then you may be use with them, but we really you to be very your participation is very important for us. So please listen, present, and give your feedback using the tools. And the tools I was saying, we have one is Menti.com. That will be really interactive. You will be using Menti.com throughout the webinar to interact with Jan and the other presenter, but also you will use for Zoom the Q&A box to type your questions or to vote the question that you think that you may need to have the answer. That is likely where you are likely to request the answer. But also the chat box, and the chat box is where you are typing where you are connecting from, the town, the country, but also do some comment for those who are presenting. Because we want this webinar to be very interactive, you encourage for those who have experience of data use and that they want to share it with all, use the hand and raise your hand, and you will be given the floor to share with us your experience on data use. And again, always we know that you like to have the resources, so we have everything here. You will have a link to that you can use after the webinar to access the resources. So you will have next we are seeing just what it looks like, what we are talking about when we say that in the chat box. Please make sure that you have all panelists and attendees selected so that your messages can be seen by all. But also we have here in visual what is expected you to do with the Q&A box. You can see that you have to click on the Q&A and type your question or use the thumb to vote the question that we'd like to see answered. And before I turn back to Jan, I would like to remind you that we are using www.menti.com and put the code 130387 to interact throughout the webinar. It's really important if you want to participate to go to open your web browser and to type what is on the desk now so that you will be participate to the series of survey that will be during the course. I will now turn myself to Jan and the other presenter for the menu that we have today. Jan?
Yeah, thank you, Alain. Just before we start, so as Alain said, we have some high caliber experts here today with us, so I'll let them introduce themselves.
Hi, everyone. My name is Heather Scobie. I come from Atlanta in the United States. I work for the what's called the Centers for Disease Control and Prevention. This is sort of like the Ministry of Public Health in the United States. And I work in global immunization, specifically vaccine preventable disease surveillance.
Hi, everybody. My name is Carolina de Navarro. I'm a medical epidemiologist here in WHO Geneva in EPI. Happy to see so many of you.
Yes, and all of the scholars will know Carolina already. So I'm Jan Gravendon. I work in the same team as Carolina here at headquarters in WHO in the data team. So let's start with the agenda of today. So we're going to talk about the data use culture. So that's a quite vague name, but what we really mean is kind of everything that is needed for people to report, to record data well and use data appropriately, right? So we will talk a bit about what the ingredients are for such a data use culture. We'll talk about what data do people need to use and why. And then we'll actually, right now I think we'll have 12 ideas to improve data use. So it's just quick ideas we want to share with you, things we brainstormed about, and think like concrete actions you can do in your district, in your region, province, in your country to actually facilitate more data use. Then we'll have a deep dive. So the deep dive will be on triangulation. Triangulation, and actually I won't tell too much about it because Heather will kind of show you some slides when we go there. But we'll talk about this new concept, which is a bit the buzz, and it's really fashionable. So it's like important that we are all up to date on what triangulation is. And finally, we would like you to invite you to share a story of your own. So people who have been on these webinars know that maybe the most interesting part is not our presentations and the slides, but in the end where people can really share their experiences in their context. And this time, we would like you to think about something that facilitated either data use or correct reporting or good recording practices or things like that, but somehow something where you had to work with frontline health workers to improve the situation and the data use culture.
I just want to add that this week, SAGE, the Strategic Advisory Group of Experts, is meeting here in Geneva, and the issue of data use is going to be discussed very much. Because it has been shown now that if you want to even improve the quality of your data, the best thing is to use it. Use your data to make it a better quality and so forth.
Yeah. So we have two fashionable items in one webinar. So there's triangulation and data use, and they're very much going together. So what are some definitions? Well, the first one there, I put their definition out as PATH proposed in 2017. And by the way, in your resource folder, I actually have like a white paper on data use that PATH produced. It's about the customs, the dispositions and behavior of a particular group or organization to support and encourage the use of evidence, including facts, figures and statistics to inform their decision making. So a very nice definition. Before we also use this one, it's the totality of knowledge, the attitude and behavior of health workers, managers and leadership towards the recording, reporting and use of data for decision making. So that's what you will read in the handbook. They say almost the same basically, but it's to say that it's not just about knowledge, it's not just about supervision, it's not just about any tools, it's really kind of like a culture, right? So this is trying to define that a little bit and leaving that definition there for you. So before we start, maybe thinking about what really do we want health facility staff to do, so people at the grassroots level. So first of all, we would like them to record accurately and completely, right? We would like them to report accurately, completely, and timely if possible. But then also use that data to identify under-vaccinated people or populations, maybe find the best way, place, time, strategy to reach them, make sure people don't drop out, so defaulter tracking. We want them to use data for session planning, outreach planning, operational planning, order their vaccine supplies, and ideally even communicate with the community, either through the data on the wall or like through bulletins or things like that. And there's probably a lot of things that I forget here, and if Heather is here and she's more into surveillance and she's an epidemiologist, she will say, well, what about detecting outbreaks and responding to them? I probably forgot that in there. So yes, it's all the use of that data at the lowest level, right? So these are the things that we're actually quite clear on what we think an ideal world would look like. But then we also know that this ideal world is not always there, so it's not always the case. So we would kind of start with a warm-up quiz and ask you what you think the top 3 reasons are why people don't always record and report accurately and timely. And I give you 6 options to choose from, and you can choose 3, just to see which ones come out on top. And the first one is that they don't know how. The second one is they have too much work, so they don't have time to do it. The third one, the tools they use are too complex, or maybe the tools they use are just not there, they're often missing. What about they get too much pressure from above? So basically the pressure is to report high numbers rather than accurate numbers, so they don't report accurately because of that. And finally, they are not motivated, right? And again, if you would like to participate in this quiz and the next one, grab your phone or your computer, open any browser such as Chrome or such as Safari or whatever it is, and enter www.menti.com and enter this code. So 130387, 130387. And a lot of people have found their way to Mentimeter, so there's 250 attendees right now, and 70 of you have found their way to Mentimeter, so that's great. We can already have some interaction. And what we see is that the number one reason that you detect is that they have actually too much work as it is. So they already have like their clinical work, and you're totally right. In many studies, it has been proven that health worker staff, frontline health workers, they spend up to 40% of their time on administrative tasks, right? So that is actually unacceptable. So now we say, okay, why are they not using data? Well, because their day is running out of time and they have to do their clinical work, and so they have no time to make charts and analyze that and do things like that. Almost as many of you think that people are not motivated to report accurately and timely. So that's also a big reason. So this motivation, and we know that of course motivation is a very complex thing to deal with. Training and is not always enough. But it's interesting to see that a lot of you also think, okay, the tools are either too complex or are missing, but that they don't know how to. That's not something you agree with, that they don't know how to enter the forms. So basically, I wanted to highlight that because often when we make a data improvement plan, the number one activity that you see is actually either training or supportive supervision. And of course, these two things, training and supportive supervision, they help you, teach you how to do something. But if we don't think that that's really the root cause of the problem, then we're not addressing the right problems, right? So what do we do about they have too much work as it is and they're not motivated? That's interesting. A next little quiz, and it's the same question, but now about the data use. So it's not about recording and reporting, but about the data use. And I put names way too small, but I think you can see them on your phone better. But the first one is again lack of knowledge, right? Knowledge at the service level. The second one is lack of knowledge at the central and district levels. The third one is a lack of motivation again. High workload, lack of time.
Lack of trust in the quality of data.
Lack of trust in the quality of data, that's also a good one. And finally, people don't feel empowered. So even if they could actually analyze the data, they actually don't have the budget or the means to do anything about it. So even if you say, well, we know where the problems are, but if my problem is that I have like a very remote population and I don't have the money or the per diems for outreach, why would I analyze the data? Because I can't really act on them. So that's like the last reason. And here actually, so it's interesting because unlike recording and reporting, you say that the lack of knowledge and lack of skills to actually use data are the main driver of why people are not using data. So people know how to record and report it, but maybe not always how to analyze it and how to use data. So that's very interesting. And then that last reason of even if they can record and report it, they don't know what to do about it. That's also another one that's driving on top.
Maybe just to remind us that, as you know, at the facility level, it's really important to use the data to identify who was supposed to come and at the end of the month didn't come. So you can follow your defaulters, your people who were supposed to be vaccinated and missed the vaccine for some reason, to see how many of them you have and who they are, so you can try and contact their families or something to invite them back. And also then to use the data at other levels to identify where you need to take different actions to invite people to come to get vaccinated, or understand why you're having dropouts, for example. People who get 1 or 2 vaccines and then they don't continue. What's happening? Are they receiving the adequate care? Do they get their card, and do they know when they have to come back, etc.?
Right. So I think what Carolina is saying also is like, we should probably not expect too much from that use of data at the lowest level. It's really simple tasks, and we should probably be able to kind of describe these simpler tasks in more simpler terms that people can actually use that and do it. But so these are 2 questions to kind of get you thinking about it. So some ingredients of data use culture. and I got this from the literature, and part of it is from this PATH publication, but I think the first ingredient would be supportive leadership and governance, kind of like the entire area of kind of having champions, data improvement teams, and actually leaders will give the right examples, the leadership and governance part. The second part would be, the second ingredient of the pie would be a sufficient, stable, skilled and trained workforce. And of course, there's a lot of words in here, but of course, first of all, you need to have enough people to do all the tasks that they're asked to do. They need to be stable, because like it doesn't really matter if you train people if they change all the time and they're reallocated and you lose all the skills. And then finally, they need to be trained, but that's probably not the only thing. But the workforce component is very important. A third ingredient, we think, are supportive tools and systems. So if your tools and systems are very cumbersome, very difficult, maybe parallel, frustrating, online, but never access, you know, then people will get demotivated and stop using it, no matter how well they're trained and no matter how many they are even. And finally, they need to have the right incentives, right? If people really think that the only way they're getting out of trouble is to report high numbers, then they will report high numbers, right? So to get people to report accurately, it takes probably a lot of that leadership and governance to ensure that people find out that they're being rewarded or acknowledged at least for using data for positive purposes, reporting the right numbers and not over-report, for example. Mm-hmm. Do you guys want to add anything to that?
Probably just the feedback that is so important to not only do the supervision, but tell the person how he or she is doing and how can do better, and encourage them when they actually improve and do better.
Yep.
Yeah, and I also like, I think that it's important that all of these, you could call them pillars, these 4 areas are really, you think carefully about them, because I think too often it's tempting to do the easiest thing, which might be to redesign or make a new cool tool like an app on the phone. But if you don't address teaching people how to use the tool, or teaching people about why it's going to help them do their job better, it's probably not going to have a lot of impact. And we need to come up with better, more effective ways to train people to do their jobs. And I think part of what Jan and Alon are trying to do with this course really demonstrates some of those evidence-based strategies that we know help people learn, adults learn better, which is interacting with the material, thinking about how to apply it to their daily life. So I think it's good as you are interacting with people you supervise to keep that in mind, that it may be easiest to just kind of lecture to someone and tell them what you know, but really helping them be involved in group discussions and problem solving and making solutions is probably the most helpful way.
Yeah. Right. So thanks for that. So going on, and I think the feedback is probably missing there, but actually we put it as an intervention more than an ingredient, because it's also part of that leadership, governance, supervision bucket. So before we go into kind of 12 ideas or interventions that we want to show you, first of all, we wanted to find out, how do you think you can make the biggest impact on data use culture? And I put 10 things out there that you could put in a data improvement plan, for example. And it goes from better training, supportive supervision, user-centered tools, SOPs, review meetings, dashboards, mapping and GIS, data improvement teams, involving the community and feedback as kind of interventions. And what you're asked to do, if you go to menti.com again, is to give points to each of these. And you actually have 100 points, and you can give all your 100 points to one of them, or you can start distributing them. But what do you think, or what are in your experience, things that really have made an impact on better data use?
SOPs, just remember, those are standard operating procedures. It's basically guidance on what they are supposed to do.
Yes. Carolina doesn't like 3-letter acronyms, so I also say that GIS is about geographical information systems, so all the mapping and satellite imagery and all these kind of things as well. And yeah, this is a bit more complicated to give because you have a lot of interventions to consider, and you will have to carefully give your points. So if you want to make a difference, don't give 10 points to each, because that means that you agree with all of them. But just think about what is most impactful. Not that I didn't put triangulation in there, because we will first have
Yeah.
to see,
To learn what it is.
see what it is.
Interesting that better training is coming out on top.
Yes.
There's still a few people, yeah.
So while people are voting, so better training is coming out on top, indeed. And for the people who actually already participated in last year's webinar on data use, actually we did a deep dive in training.
Oh.
So this time we haven't included because we do a deep dive in triangulation, but just to say that in the resource folder, actually I put the entire last year's webinar so that you can actually revisit that if you're really interested in training. Also, like some training company with support from the Gates Foundation invested in development of 10 very short PDFs, so very short documents of like 3 to 5 pages each, on best practices for different aspects of training. So how do you do a classroom training, how to perform on-the-job training, etc. And they're very interesting to read, but we couldn't really address all of them. So I put them in the resource folder again for you to see, and they're there. But it will be self-study, so we won't really be talking too much about it. Last year, the main message was that in training, actually, you learn most from on-the-job doing. You learn also quite a bit from interactions with other people and mentoring and peer networks, and you learn less or the least with formal classroom trainings. So that's not to say that they don't have a place, but they should have a limited place in a bigger strategy. That's it. Right, and as most of you have voted now, or at least 120 out of 320 people have voted, so better training is the winner, I think. Supportive supervision is also very important. User-centered tools, and that's quite interesting. You also acknowledge as maybe having a big impact. Review meetings, data improvement teams, SOPs, feedback involving the community in mapping NGS and dashboards all get some points, but it goes down from training.
And just to tell you that the evidence shows that really not doing only one thing is what helps. You should do multiple interventions to get it better. So you need to do supervision at the same time you are doing feedback and revision and the right incentives involving the community, etc. So this is very important that you are voting for a variety of things.
Right, so thank you for voting. We're going to stop it here and then actually go into the intervention. So maybe Carolina, do you want to take the first one?
Okay, so one of the areas that was mentioned was about the tools, right? And you really need to understand the processes, right? What people have to do their job, where the data collection starts, how it flows. And here in the screen you have an example from JSI on how registries can be based on the names of people. So writing about one person, following the vaccination history of that one person in a book, or then in an automatic electronic system, or just counting how many people of a certain age, for example, get different vaccines. So first thing is to think about what is the process and where you want to get to establish really the workflow. So put yourself in the shoes of the people who have to do this, so you can design how the tools are working, what is easy to do, is there enough space in the form to write, do people have pens to write properly, and then see how they are working in that flow of work, and how you need to revise the tool if needed.
Yeah. And just to say that this thing comes from JSI, this picture, and actually there's a small document in your resource folder that is made by JSI that talks a little bit more about these things. An example of maybe very user-centered tools are the tracking bags. I think I really like these.
I love them.
They were made this is from India, but also in the Americas, they use them a lot, where people start thinking about, okay, this register that we have, it becomes too cumbersome, too large, too big to carry. And actually, like, why don't we give the nurses a bag that they can easily bring on their work as they go to outreach? So because in India, most of the immunization services are delivered in outreach. So they said, this is a much more user-centered approach for that.
Mm-hmm. And what is beautiful is that you have 12 pockets, so each pocket is a month. So you know who should come in January, and at the end of the month you check whose card didn't move because they still didn't come. So you will know at the end of the month who is missing, and you can do your planning, and you move them to the next month in case they come. And so it's easy and not so heavy to really understand how people are coming or missing. And you have each card for an individual person, so you understand the person born in X days, how his or own schedule is advancing as they get older.
And there's a link there to the immunization basics page where you can find more information about how it exactly works. Job aids and SOPs, just some kind of tips for job aids and SOPs here. Simple, visual, physical, and actually created for the people who do the work in mind. So user-centered again, don't really don't really dream it up at the central level and think that people understand it. Try to pilot it and test it with them.
And explore what people are already doing, because the good ideas are always in the field.
Mm-hmm.
Somebody already did it.
Yeah. And we talked about how kind of, if you do field reviews with your data improvement planning process, if you do a DQS, you do field reviews, try to take pictures of these best practices, take them back, and see what you can actually use as national level tools. Better training is number 3. Actually, it was number 1 in your list. But just to say that in your resource folder, you will have a set of 10 PDFs. One of them is actually specifically training for data quality and use, but there's also like more generic ones that talk about how to do a classroom training, how to do mentoring and everything. It's very interesting. Let's not go too much into depth here because we don't have the time, since we will focus on data triangulation. Organize review meetings. Everybody does review meetings all the time, so the only question is really kind of what is the quality of those things. So when we look at kind of what works is, first of all, make it collective action. Let people look together at data and see what they can do together to improve the performance or the quality of their data. And then peer support and mentoring, of course, really works in that. Does anybody want to add something about review meetings?
Super useful. Do them and do them with an open mind, so everybody benefits from them.
No. Also to say that they need to be done at all levels, so they can be done at the lowest operational level districts with the health facility workers. They should be done at the regional level, also the national level, and in the end, it's also a data quality requirement to have like an analysis of your data. So have like a group analysis of that. Let's have people look into that and make sense of the data.
I guess I'll just add about the review meetings. I've been working in one country right now intensively, and I've noticed that the places I go to where they're not doing the monthly meeting, they're often the more poorly performing areas. So I do think, just anecdotally, that I noticed that the better performing areas take this exercise really seriously.
Yes. Dashboards is often something that is done, and if we say dashboards, we often think about computer systems. Just to say it doesn't have to be a computer system. Here's an example from, I think, Cross River, it says there, so that must be in Nigeria, of people that do a dashboard and they're analyzing their logistics performance in this case. So what they also did with that is they organized a competition, actually they called it a league, to see who was leading in the data quality or in the logistics replenishment, I'm not sure, competition.
Yep, feedback and really comparing yourself to the neighbor, it helps when it's done with the idea of improving, not when it's just to in paper look better, but in reality have your community better vaccinated.
Use maps for data visualization and microplanning. Here's an example from Myanmar, where the Health GeoLab is actually working to really map immunization communities and make sure that they can all be served by microplanning. So I think right now the state of the art is basically often that people develop kind of hand-drawn maps or croquis or something like that. And the problem is that you often, of course, miss people and communities. So really kind of, we think it's kind of time for it's the era of GIS and microplanning and even Google Maps. People actually have access to those, and why not use that information for better planning, detecting gaps, and rational planning of services and outreach.
Right, and use also the microplans done in campaigns. because at the time of the campaign, they get updated, and some communities that have suddenly appeared, urban areas, etc., they will be there. So use those also for the routine.
Yeah, in Nigeria, when I was working there, they had these really great technology. They had vaccinators during campaigns wearing GPS devices, and you could watch them walk around on maps and actually see little communities and settlements that had been missed, and those actually got incorporated into the routine immunization microplan. So that was a really great innovation.
I don't know how they call them, the such and such buster. Somebody from Nigeria can help us with that. Just to say that polio effort was kind of very, it was very expensive actually, so it might not be scalable to all places. We have the entire idea about data improvement teams and champions who together can review and develop tools, job aids, organize review meetings, and organize cascade training. So probably a very good idea. We don't really have, I don't really have any knowledge about an evaluation or a systematic evaluation of that, but just to say that in your resources, there's an example from JSI in Ethiopia where they talk about those data improvement teams.
And if you're doing them, please document them so the evidence can start to be created.
And share it with us.
Yes.
CDC, I guess, has one recent paper from Uganda talking about the impact of these data improvement teams, and they're continuing to document how successful they were. Maybe it's something I could give to you to share to the group. Yeah.
And I think also if people are here from Village Reach, I think you guys are also working with data improvement teams as well as PAF and JSI. So it's actually something that is really taking on. So if people are on the call, don't hesitate to kind of come and share your experience at the end of the call in the last half an hour. One thing I particularly like is involving your community, because I think that one of the main sources of pride and motivation for health workers is if they can talk about their data with the community. So actually I have this medallion that's actually given to health workers in Nepal once they can use their data to show that they are a fully immunized community, as they call it. So I think that was a very nice example, and I think sharing it with your community, the data can also probably increase the transparency. I've even seen an example just now in Indonesia where on the wall there was actually a list of missed children, and then people who visit could actually say, well, actually those children moved or whatnot.
Remember, positive incentives work so much better than negative ones. Incentives help people, encourage people to do better, not punish them for not doing so well. You can always do better.
All right. Create virtual networks. So I think you're all on WhatsApp, Facebook, Line, mostly WhatsApp, probably, WeChat in China. So yes, data use is probably kind of also really kind of being helped by having those virtual networks in place, and all the peer support that comes with it.
For surveillance, these networks are super important to report, to alert, to ask what to do, etc. So again, share your experiences as you have them.
Carolina mentioned it, so you want to...
Feedback. You always want to know how you're doing and how you can do better again. So let them know why it's important, how they are doing, and how they can do better, and encourage them once they do better. So I think that's already beautiful in the slide.
Yeah. It's also like it's important to give meaningful feedback, not just to say, well completeness was it and that, and time minutes was that, but really also like, maybe integrated together with those data improvement teams or the review meetings and things like that. But you all, as professionals, you know like how important feedback is and supervision.
Yeah, it's actually a type of incentive, right? I mean, I think one of the biggest complaints I get from the field is that the data is just going into some black hole and nobody's ever hearing back about it. So it really lets people know that they're important and what they're doing is important.
Measure what matters. So what I would try to say is kind of trying to make people accountable for what they can control. So the problem is often that people are kind of measured on coverage, but then they say, well, I don't control my denominator, or my denominator is wrong. Well, in those cases, why don't you start like looking more at numerators? Like, did you vaccinate as many children as you did last year, for example? It's a very more comprehensible thing to be measured upon. Or what is your dropout rate? Are there many children that go missing? Might there be unvaccinated in your community? Or what are measures of service availability and readiness? For example, is your health center open 5 days a week or whatever the policy is? Can people easily access? And then finally also, like if you measure what matters, there's a picture there from Laura Shimp and GSI, which is the data on the wall. And you all see, if you go to health facilities, you see often like data on the wall there. So what people communicate with those data is sometimes what they take prize in.
Mm-hmm. No, I think we should go to triangulation. Maybe people are waiting for more triangulation.
Okay. So we'll get there. So here is data triangulation for immunization and surveillance program. So before Heather actually takes it away, I kind of just programmed the same quiz as you did in Budapest,
okay, cool.
So that can people also do that.
Okay, so this is the outline of the talk. We're going to talk about the definition of data triangulation, give an introduction to the framework we prepared and examples. I think Jan may have put this framework on the share drive, or maybe we can. And also we'll talk about the national and subnational guidance we're developing and some of the pilots we're doing in countries. So this is a quiz we developed, and it would be cool to know which of the following best matches your idea of data triangulation. This was an exercise. So if you could use Mentimeter, go to mentimeter.com and use the code 130387 and give us a vote on what you think, and we'll see the dots start to move to the different answers. We did this quiz first at a big meeting in Budapest when we first started talking about the results of our a big exercise we did to define what data triangulation was. And it's really interesting to just see, you'll see as the dots are coming that people have a really different idea about what data triangulation is. For some people, it really means validating data quality. Some people think it means comparing at least 2 data sources. Some people think a triangle, like that obviously must be 3 data sources. But just to point out that everyone has a different idea. So I'm going to, okay. So we started at this point with, as Jan introduced, that basically there's increasing use of this word. It's kind of a buzzword, but not everyone has the same meaning when they're talking about it. So it's a little hard to develop materials on how to do this effectively. So we convened a group of experts, actually right here in Geneva about a year ago, and we made a definition, which is critical synthesis of existing data from 2 or more independent sources to address relevant questions for program planning and decision making. And the key parts here are that it is a process that helps identify and address the limitations of any one data source or different data collection methodologies. And also in the process, I think you'll find that you'll get deeper insight by making sense of complementary information and the broader context. So we made this framework, which I said we'll share, and it includes a landscape analysis of different triangulation methodology and examples, especially from the EPI, and also from HIV. So they actually have the most extensive tools on data triangulation. And we did a number of surveys, including of global people, but even national and subnational staff. I wonder if some of you participated in this survey. We just sent it through our personal networks, but we got some interesting examples back. And as I said, we presented this at a meeting in Budapest, and also the groups that Carolina mentioned, the SAGE Working Group on Data also reviewed this document. So in the process, we actually identified that data triangulation for EPI, or the immunization programs, it's not just for data validation. You can use it for checking consistency across sources, which would be like data validation, but also as a diagnostic to target program interventions. You all might be familiar with the concept of a risk assessment. That would be a good example. We can also use it to estimate coverage, target populations, or disease burden, to evaluate the interventions and the impact of interventions like campaign and vaccine introduction, and also to do holistic assessments of how adequate our program is. So examples of this might be like during an outbreak investigation, when you really have to do a deep dive into what the shortcomings of the program are, or for disease elimination verification processes. So this is an example of the last one I just mentioned. So when you verify measles, rubella, and congenital rubella syndrome elimination, you actually look at all these different threads of evidence. And you can see in the center that this is a great example of triangulation. It's, looking at all the evidence, asking, is it valid? Is it complete? Is it representative? Is it consistent? This is another example from India of estimating the national and subnational vaccination coverage. And so on the left is a process that happens at the global level. Actually, Carolina's involved in this, where you generate what's called the WHO UNICEF estimates of national immunization coverages. So these are kind of like the best estimates of what the real coverage might be based on all the existing data. And then on the right is an example of a subnational estimation activity that was completed recently in India. So they got these kind of best estimates for all of their subnational areas. This is another example of how over a long period in a country, you can see that increasing DTP3 coverage or penta coverage has really led to decreases in diphtheria and pertussis cases. At the subnational level, where you all might be working, you might see things like if you're having repeated outbreaks in the same area and they're reporting high administrative coverage, you might ask yourself, is this a vaccine quality issue? Is it a data quality issue? Or what are the other factors that are going on here? This is another example of a tool I probably won't get too far into, but you might want to research online. It's called an age cohort analysis, and this is really looking in depth at your surveillance data and your coverage data over time to see where the gaps might have been in coverage, resulting in population susceptibility. And you may find that when you match this up with your surveillance cases, that all of your cases are occurring in these birth cohorts that had poor vaccination coverage. So right now we're working on guidance for data triangulation. We're calling this kind of a program refinement tool. It's actually something that's been done for a really long time, and it's kind of a best practice, among immunization practitioners or public health practitioners. And I think the idea at this point is really just to make sure that things are written down and that people have good guidance on how to do it well. So we're taking guidance from HIV and also some work Jan has done on the data quality review process, which you may have been introduced to. And we're trying to broaden it to address a variety of important program questions and incorporate use of disparate data sources or different data sources like surveillance and vaccine supply. And we really want it to be less of a new a new like fancy tool, like a computer tool, and more of a helping reinforce a critical thinking process. And right now we're doing exercises in 2 countries, and we hope the guidance will be ready in the next year. So there will be advanced guidance, primarily targeted to the national level. This will be more like an in-depth analysis or research project in terms of implementation. And we're also going to have some different entry points or examples about assessing immunization data quality, VPD surveillance performance and data quality, immunity gaps, and also assessing immunization target population denominators. And there's going to be a 10-step process. I think that's here. So this is the 10-step process, the advanced process. I've gotten some feedback that this is a little bit overwhelming to folks, so we may have to repackage it a bit. But at the core, there's a planning phase, there's an analysis phase, and really important that the results are actually used for action. And the 10-step bit is really just walking you step by step on how to do a good analysis and what to consider at each step to make sure it's really nice and complete. The minimal criteria for doing data triangulation are quite simple. You just need 2 or more independent data sources, some data management and analysis capacity, and the willingness to take action on results. The format is really going to vary based on the level that you're working and the frequency. These are some guiding principles. One, that it should be objective-driven, so really targeted at the most important program questions, using existing data, including diverse data, and engaging a multidisciplinary team. So different people with different expertise and access to data really helps and really makes the experience a lot more interesting. Focusing on basic analysis and interpretive synthesis. So adding contextual information, doing basic data visualization, more than fancy statistical analyses, and then using results for action. This is a simpler data triangulation process for the subnational level. So this is focusing on 4 steps: asking a key question, identifying existing data sources, and summarizing data with a local knowledge and developing an action plan. And we're looking at making simpler tools for this, including some job aids. So I think this is the last slide. It's talking about how countries would benefit for data triangulation. We find that we have an increasing number of data sources, but the human capacity to process this data into usable information is really lagging behind the technology. So more and more countries are getting these fancy, DHIS2 and other systems, but when you ask people, they really talk about, oh, someone's taught me how to enter the data into the system, but I don't really know what to do after that. So triangulation is a tool to better understand and appropriately address key program issues. And the proposal of this work is to really help build the capacity of EPI staff at different levels for data analysis, interpretation, and use of data for program decision making. And this will include like mentoring staff, incorporating triangulation into existing tools, and identifying the need for new processes or tools in the future. I remember that there's one more slide. It relates to what Carolina was talking about earlier, and that's the SAGE Data Working Group that will be presenting tomorrow in Geneva. And this group, which I'm a member of, actually really thinks that data triangulation should be the default for public health analyses. And it allows you to make better use of all your existing program data. So maybe something for you to take home is to think about how you could better use your surveillance data with your immunization data. So that an example of that is on the left. And then maybe start to get familiar with, if you have a logistics management information system in your country that has stock data, or you have access to this data, start to look at the relationship between the doses administered and the doses that were available at the subnational level and those doses used, and look at the relationship between those things. So the doses used should pretty much have a really direct relationship with the doses that are reported to have been given. And you may start to see interesting relationships where, you know, limitations of stock at the subnational level are really having, you know, a negative impact on coverage, and you can start to sort that problem out. So I think that's it. Thanks for your attention.
Thank you very much, Heather. So that was very interesting. Just to add a few more things to that, for people who have been in the SCHOLAR program and have done the VIP course, so you will have had a case study either last year or this year. You have done it already on the Vexilent case study. So in my opinion, that's actually a little bit of a triangulation case study where you're in a country that has high coverage, administrative coverage at least of measles, but you also have all of a sudden outbreaks, right? So now you're trying to make sense of that. So what you're really being asked to do is kind of do triangulation, looking at those different sources of data, keeping in mind that none of them, or one of them at least, might not be that reliable. So it's like, it's all these questions. Also to say that for the level 2 DIP, which will be coming next year, we will really look to make this kind of a cornerstone of that level 2, and really make sure that data triangulation is really front and center of that, and see how we can use those methods. And then finally, I would also say that, and this is maybe a comment, but also maybe a question for Heather, that is, if I would be, for example, sitting in a local government area in Nigeria, and this really resonates for me, I said, well, this is my problem, so what do I do now? Is the answer you should wait until May 2020, or are there things you can already do before the guidance comes out? Can we find inspiration from the framework, or from case studies, or from other things?
Well, I mean, I can't speak exactly to Nigeria, but I will share that I just came back last week, actually before I came to Geneva, from Bangladesh, where I gave a similar presentation there, and I visited the subnational level, and one of the officers there, who is actually, I think he was a graduate of this course, he had already, just based on what I presented, he started, he was doing some of the data triangulation, but he really liked this stock triangulation that I presented. And by the time I got to him, which was a few months later, he had already made all these wonderful charts and put them up in all of his his clinics that he was responsible for. So he was really implementing and looking closely at this issue of matching the doses used to the doses given, and really using it as a way to check the data quality of his places where he was reporting. And one of the things we worked on in Bangladesh at the subnational level, they do a great job with making reports about measles surveillance data. They make graphs, but there wasn't a lot of critical thinking about how that data related back to the performance of the immunization program. So we looked in detail at the age and vaccination status of those cases, and we talked about how, you know, having many unvaccinated children in the 9-month to 4-year age group is really a sign that the program isn't reaching everyone that they say they're reaching, because a lot of the coverage there is close to 100%. And we also saw interesting things like young children, 1 year of age or 2 years of age, who were also, it seemed to be like that they had delayed vaccination. So that's another thing that you can actually see in your surveillance data if you look closely enough, and also looking where the cases come from. So in this case, I'm talking about a setting where they actually have pretty good vaccination coverage, and you can really use it to find immunity gaps. it may be that in your country you have a lot of measles cases and you're not there yet in terms of really being able to target and focus. But I think a lot of you are really creative, and you're probably doing some of this already, and it would be great to talk about some of the things you're doing.
All right. Carolina, do you want to add?
Just to add that this is the triangulation is becoming a detective, a data detective. And this is where you become Sherlock Holmes, follow the clues, and then the clues will give you more questions that you try to answer and more questions. So don't wait for documents to your question. Really start looking at your data and trying to think critically about it. Why? And look at the data you have. And if you don't have the answer, try to find what data can help you find the answer eventually.
All right. So I think there have been really good and supportive comments in the chat box. A lot of people are very happy to be in the discussion and learn a lot, and think it's a great discussion. So I think we have plenty to talk about. I think we can hand it over back to Alain. I think there's a lot of questions in the Q&A box. And then we would also want to hear from people who can maybe share some experience, like either with honest reporting, better use of data for action, or maybe even we have the gentleman from Bangladesh that just worked with Heather that can explain what they did. So over to you, Alain. And
yeah. Thank you very much, Jan, Heather, and Carolina. That was impressive. So we have a lot, like we say, we have a lot of interesting questions and comments. So I would like to invite you to turn to the Q&A. You can see that one of the questions from Amajo Kaur had like 29 votes, another from Fitwi Meles. So for the two ones, so first of Jan, if you want to, before we dive into the attendees who has experience with data use, and we would like to hear from them, so they get themselves ready by raising their hand, and we will be able to let them talk. So first we'll turn to the question of Amajo Kaur. So Jan, if you want to, or any other panelists to address that question.
Okay, so let's take the top questions from Amarjot Kaur, I think from India. I think a lot of data is collected at service level or district level, but it's not utilized for decision making at district service level. How can we ensure data use? Do anybody of the co-presenters want to go first?
Okay, so to use the data, you have to have a reason to use it, right? So what do you want to achieve at that level? You want to make sure people are vaccinated. I think that's the common goal we have, is to vaccinate everyone, no matter where they live, in terms of if they live in an urban or rural area. So in your area, you want to vaccinate your population. So how can you ensure data use? It's encourage the people who need to use the data to use it. So ask questions. So if you're the supervisor, you can ask, how are you doing? So you can look at how you're doing compared to last year, compared to last month. How are you doing with your DTP1 compared to your DTP3? Are you missing people along the way? Are you missing people for measles, for example? And if so, why? What's happening? You don't have vaccines, or do you have vaccines all the time? So really try to ask the questions so that the people who need to use the data need to think about the answers and look at the data in order to answer. I think that would be my first idea. And not try to make it too complicated, because at the end of the day, we want to vaccinate everybody. That's it.
So maybe, Alain, can we unmute Amarjot's phone maybe, and maybe she can say if this is kind of answering her question, or if she has specific situations in mind.
Yeah, that's a good idea, Jan. Amarjot has been promoted as a panelist, so he or she can just unmute his mic by clicking on it, and he will be able to talk. Amarjot, can you hear us? Please go ahead and unmute yourself.
I guess I'll also add, in terms of data use, I think it's something like Carolina was saying, it's a hot topic right now, and I think I take some responsibility for trying to ensure at the global level that we really try to create better tools and training around this. So I think that that's part of what we're doing here. Part of what we're trying to do with data triangulation. So how can we make this a more fun and relevant, you know, a process using data. And also when I go to the field, I try to lead by example. So when I'm doing supportive supervision, I basically try to start by doing some data analysis, some data triangulation before I go to the place that I visit. And I try to find like one thing that I find a little bit interesting about the data, either the performance of the place I'm going, or there's something a little bit strange about the data that I notice, and I use it as a way to sort of get a deeper understanding of the place I'm visiting. So it gives me a place to start talking with the staff at the facility where I went, and to ask them about, you know, why do they think that this thing occurred, and to really get into it with them and help them solve the issue that they're facing.
Thank you very much. I can see that he's not, Amarjot cannot speak, but like, Hyun, please go ahead for the second question with a lot of vote. I think that is from Fitwi Meles.
Yes, and can you give her or him maybe the floor to ask the question and see what is needed?
So the question says, practically the ingredient of data use culture are missed everywhere. What does WHO and CDC thinking on this area to bring a fast improvement in data use of immunization data?
Yes, I understand that, Alain, but I just wondered if you can unmute his or her microphone so that she can say, or he can say what his or her perception is of the real situation.
Yeah, definitely. Fitwi, good afternoon. Can you hear us? You have been promoted as a panelist. You can just unmute yourself and the floor will be yours. Fitwi? Hello? Yeah, unfortunately, he seems not to be able to.
Can you hear me? I can hear.
Okay.
Yes, we can hear you. Hello?
Yes, please go ahead. So Fitwi, can you ask your question and say why you're asking this? So what do you see is missing in everyday life in your context? So Fitwi, are you there?
Can you unmute yourself?
All right, so while you're maybe trying to connect, we can maybe answer the questions, and then if you're able to connect, it would be nice if you give us your perspective. So you say the ingredients of data use culture are missed everywhere. Are you there now, Fitwi?
Yes, yes. Okay.
Get the floor.
Yes, actually, my question is straightforward. That as we have seen in the presentation, we have seen this data use culture has different components, and practically, really, in immunization data and at the ground level, we really are suffering of all these components. So, just as a big organization, CDC and WHO taking initiative on this data improvement, every country. So what do we look forward in the near future that all countries are really adapting or utilizing a good culture, utilizing a data use culture everywhere at their health facility level? Thank you so much.
Yes, thanks, Fitwi. So we can start, but then maybe we can also hear from you. So what is most missing, and how do you think it can be done in your country? And maybe also telling us where you're from in that case. I I would say like it's not easy to build a culture. It's really kind of long, overnight. It's not overnight work. It's a long slog. It's a long project. So WHO and CDC, I think we can try to help by giving you some of the methods and the tools, but really, it really will depend on national governments and other people in the country that work with the innovation program to kind of little by little start making an impact. So I'll start with my point of view, and then maybe you guys can add. But I think a lot of these things need to, first of all, start from the top and kind of by showing leadership and by showing good practice and being supportive of that. I think from the top you can make a lot of difference. But I think the best ideas actually often are generated at the bottom as well. So at the same time, you have to really look for those best practices that are there in your country, that will be there, and see how you can share them with other people. And then little by little, try to make little improvements in this culture. And I think that once people see that data use and reporting good quality data is being appreciated and even acknowledged and rewarded, then this culture will establish itself more and more. But I kind of... I
want to say that you can make the difference, right? You are the scholars, you are the people in the country that you now, after this webinar, look at your own data, look at how you're doing this year compared to last year, and tell us about it. Because by sharing between us, with your peers in your own country, in other countries, we can start creating that culture where people ask questions, why, and how do I make it better?
Yeah, I think that you all are uniquely positioned as kind of leaders, I guess, coming out of this course to really go back and share what you've learned, and that I think that kind of demonstrated leadership will probably have a more impact than actually me or anyone else from outside visiting the country and trying to share what we know. So I really think that the impact of local leaders, I really see how that really strikes people when I'm in countries and I'm working with really talented local immunization staff, and how that really helps galvanize and get people excited about data.
Yes,
maybe a question for you, Stephen. First of all, what country are you from? And then second, can you share with us what you think the biggest challenges are, and maybe something that you have done to already start improving it?
Okay, thank you so much. Originally, I'm from Ethiopia, and now I'm new to Malawi, almost 2 months since I am here working for CDC WHO STOP program. So basically, I think an example was given from the experience from my country where JSI is working on. So I mean, having a good contact at the community level and health facility level, reviewing the data and more closely monitoring the data by the lower program is the most important point that I had an experience. So why I really asked this question about is the finance and the capacity building challenge is everywhere in all the countries. So you don't get them anytime whenever you want to capacitate people or whatever you want to review a program very closely, regularly. You don't get all this facility, all this finance and technical expertise as well. So that's the reason why I asked it. So when I come here to Malawi, like the same problem that we have been even suffering in Ethiopia is really happening here. They really don't review their programs regularly. Whenever you visit a health facility, you really see people. They only focus on the figures, but not triangulating, as you mentioned, and of course even they don't try how far very reliable data is coming from the health facility, from the clinic level to higher level. So all these things, I just feel, of course, in the areas like I had in Ethiopia, where JSI project is being implemented, I can see, I really saw that a high level improvement has achieved in that area, but it's not all over my country that this data that we can say has improved a lot. So the same is what I am observing here in Malawi also. So this technical expertise, a regular basic financing this immunization program for data quality and taking data is a very, very important tool for program improvement is the most important point. So it's just from this kind of view that I asked this question. So I think through the discussion of your presentations, most of the challenges that can happen really are addressed, I feel. So this is just a kind of, with the time we have, the kind that I share my experience from my side. Thank you so much.
And thank you for again for your leadership and for your service.
Yes, Jan, thank you, Fitri. And then, like was saying, Here and Carolina, one of the comment that we had from Scholar, Scholar taking the course is like, you know, using the course they are taking on with webinars to, at the end, develop a plan that is meaningful and change. That can be the one that they will use to then advocate at the country level for the use of data using the innovative strategy. So very, very good comment from Scholar taking the course too. So thank you, Jan. If you want, we have other questions who are not like 17. So maybe we'll turn now to participants who would like to share their experience at their country level or district level. So
if you want, we would actually like to answer like the next 3 questions still, because I think there's good questions there. But maybe we can just quickly answer it and then ask people to raise their hands to share an experience. But first, is there a particular library for EPI resources, including a site for standard collection tools? The short answer is not really. It's a bit disparate what we're trying to do, and need to make more of an effort on that, but kind of have as many of these useful resources at least referenced in the handbook. And just to say also that going through this course with you all together is very useful for me to actually finalize that handbook, because then I can see more what is needed, but also what is available, and make sure we try to have as full reference library as possible. Standard data collection tools, yes, they should also be there, and I agree, and that's not always that's easy.
If I may add, there is a standard repository of home-based records of vaccination cards, and there is a library of tools that you might find some information in TechNet 21. So if you Google TechNet 21, you will find a library of resources. Again, may not have everything you're looking for, but maybe some of them.
Yeah. And all of that is referenced in the monitoring handbook.
Yeah.
I think the next question, how can we ensure sufficient, stable, skilled and trained workforce in poor countries where politicians decide who get appointed to what position? That's a very good question. To be honest, like even at CDC and the WHO, we're sometimes a victim of that. But politicians, yes, I think.
I would say you have to work with what you've got. So you have to motivate the people that get put in place, and make do with the people you have. And again, because our mission is so important, I think anybody can at least get motivated and try to do better. And with supportive supervision, with feedback, you can improve people's performance, even if with the constraints.
I also think that once you get to be known as kind of a leader and very kind of skilled and kind of a thought leader in a certain area, people will refer to you, even if there is kind of going to be changes in leadership and everything. There will be the best people will always kind of somehow be recognized. We hope, at least. That's maybe an optimistic take.
I mean, to the extent it helps, I think we're also, like Carolina mentioned about this policy group that's we're convening tomorrow, and we're going to be making recommendations which we hope are taken up by national governments to make sure that all aspects of data management and collection are properly resourced. So really paying better attention. And there are some tools along this line too for country program managers. It's called the Immunization Competencies Framework, and it's about really making sure that your staff, the way that you have allocated your staff and the way that the skills that people have is really appropriately matched to the needs of the program.
So that was Yaya's Camera's question. We have a question from Monica about incentivization, and if you say like if only 1.6 of GDP is going to healthcare, how can we incentivize every accurate data entry? So I think here and I'll start and then you can complete, but I think really the key is not necessarily to pay people for data reporting. The incentive really can be other incentives, can be positive incentives that are other than money only. So people get their salary, but maybe it's about recognition, receiving feedback, being highlighted as a leader or as kind of having produced the best practice. I think it's those kinds of incentives we were talking about.
And you will see outliers in the world, for example, countries that Nicaragua, Honduras, sorry, I know Latin America better than other parts of the world, that they have a low GDP, yet they have really good immunization programs because they make do with what they have in terms of motivating people and that commitment to serve the population. It's really what drives people. And of course, people should be paid properly, etc. But even in worse circumstances, you can try to do your best, and everybody needs to have that in mind that we can all do our best with what we've got.
Being recognized in your community is another one that is very important.
Yeah.
So I think, Alain, we answered the questions with a lot of likes, so maybe we can challenge participants to come up with kind of examples and suggestions.
Yes, sure, Jan, and then we have a lot of participants raising their hand. I know it's very interactive. Everyone wants to talk, so I will now turn myself to Mariam Ogo. Mariam Ogo, if you can hear me, you just click on your mic, unmute yourself, and the floor is yours about your experience in data use. Mariam? Mariam? So unfortunately, Mariam is not able to talk to us. I will see if Thomas, good afternoon. You can just unmute yourself and the floor is yours. Thomas? And good afternoon, Thomas.
Thomas? Yeah, good afternoon.
Yes, Thomas.
Yes. Yes, can you hear me?
Loud and clear. Loud and clear.
Very good. I'm Thomas from Ghana. Yes. I'm looking at trying to actually improve data at the facility level. When the registers that are used to capture the data are very simplified, and those at the facility level are trained enough to understand the kind of data they are collecting, they actually make a big difference. Like, for example, when immunization, you collect data including as the house number or locality of the child, and then they are able to track when the child is default in terms of coming for subsequent immunization. Health workers are the actually follow up and trace that. And so I think that some have to
Thomas,
yes. Hello.
You are breaking up. Your connection is breaking up.
Okay, sorry. I'm talking about if the data that is being collected is understood at the source level, the facility level, we can actually make good use of it. And the classical example is in Ghana, where I work. We have these simplified registers where the children on immunization, all their details are captured. And so they can use the addresses, for example, to trace defaulters. Those dropping out of the schedule can be traced, and they will turn up for the subsequent immunization. So in terms of data usage culture, them with skills enough to utilize such data.
Yes, Thomas. Unfortunately, we couldn't hear. Are you there, Thomas?
Yes, I'm there. I'm online.
Yes. I will now. Unfortunately, your connection is really breaking up, and I will see if Jan, Heather, or Carolina could. I mean, if they heard your question or your comments.
Okay.
So yes, I think we understood a little bit, but not very much. So Thomas, if you can send us also maybe your comment, also maybe through the Q&A, that will be helpful, and then we can maybe try to even do it in a written way. But what I did understand is that you kind of talk about simplified registries, which I think is important. Actually, try to simplify, because as we said, kind of during the years, as we introduced vaccines, we kind of introduced the need, for example, we think we have the need for gender disaggregated reporting and all these things. And we kind of make the registration and the reporting more and more complex. So I think if you say simplified registers that really focus on defaulter tracking, I think we would definitely think that that's a great idea. But for that, I didn't capture much.
I think I seem to have understood that people were focusing in making sure the children completed their schedule and using that data to do that. Is that correct?
And so once they are the use of the data at that level.
So sorry, Thomas, I think we really don't understand you enough to really provide meaningful feedback. So I think what Carolina said, like defaulter tracking, yes, simplification of the register, yes, absolutely. I would say send us your comments or question in the Q&A, and we will try to come back in the written way, because we're also running out of time.
Thank you, Jan. Sorry that we couldn't hear Thomas. So I would like to invite Olivia Ateba Wokolo, but also Clément Akampeje. So Olivia, good afternoon, Olivia. Can you hear us?
Good afternoon.
Right, Olivia, the floor is yours and you are loud and clear.
Okay, thanks very much for giving me the floor. I'm going to share an experience with respect to our situation where I am. Like the other participants have said, the first problem mainly are the tools, especially the data collection tools that are very cumbersome. Where, like the vaccination register, where there are many things to fill, and there are many other tools to fill also, like the infant form and the carnet of the child. So at the end, the health personnel takes what is easier to fill and leaves out what he thinks it is more difficult to fill. So that is a problem at the level of data collection. Now, at the problem of at the level of data collection, tools not harmonized. At where I am, we have like the tally sheets that are not even available. So everybody tries to make what he thinks he can use for collection of data. And also the absence of analysis of data before onward transmission. So at this level, what I've tried to do is to motivate when I go to a health facility, like for a supportive solution, and I see that a health facility during the end of month meeting came out with problems of EPI and tried to come out with solutions to solve that, it gives me an indication that they at least understand what they have to do. That is, they know that data is not only present to the hierarchy, but they also can analyze the data, make use of the data at their own small level. So at this level, I try to motivate people to do that. Now, with respect to the non-harmonization of tools, you see that like in my region where I am, I try to come up with a uniform tally sheet and give all vaccinating health facilities so that when somebody goes to the field to do a data quality self-assessment, there are uniform tools to come out with the problems and to try to solve for solutions. Now with the problem of too many indicators, too compass register, that could be managed at the level, at the national level. Because for registers that are already put on the field by the National EPI program, it cannot be changed by anybody at the field. So that is, in summary, what I wanted to share.
Yeah. Thank you. Olivia, stay with us. Jan?
Yes, so maybe Carolina, do you want to start?
Well, I think that we encourage you to continue doing what you're doing of trying to streamline the tool that people are using, understanding that they are cumbersome, and please share that what you're doing with us in written format so we can also share with other participants who will see this recording. Thank you.
Yeah, I would also say that kind of the simplification is really one of the most important things. So we can't keep on blaming people or actually training them more, because they often, as you said, like they come to the extent to which they have like really more and more administrative work, and it's really taking over their normal job. So we should really focus more on making the job easier for them, first of all.
Right. Olivia, and then 5 minutes remaining, Jan. So can we go ahead with another participant, the last one?
Sure, I think we have time, and then we just have one small announcement about the next webinar, that's all.
All right. Thank you, Olivia. Thank you very much for your contribution. I would like to turn myself to Omolara Adeyemi. Omolara, can you hear us? Good afternoon. Omolara? And we see also if Clement Akampeje. Clement, good afternoon. So it seems like we don't have Clement. I would like to invite Kura Juf. Kura, good afternoon. Can you hear us? You just have to click on the mic and unmute yourself. Kura? But also Dance Hidansh.
Hello.
Good.
Hello.
Yes?
Yes, I'm Dines from Tanzania.
Good afternoon, Dance.
Good afternoon. How are you?
I'm fine, thank you. So, Dance, the floor is yours for your contribution for the data use, the practical experience.
Yes. So I came from Tanzania and I work for PATH, and we have been supporting electronic immunization system for BID initiative, which is a better data for better decision. And through the program, we have learned that a tool itself will really support healthcare workers to be able to use their own data, because the electronic immunization registry that have been developed is now within nine regions in the country, and the electronic immunization system is able to automatically generate reports where healthcare workers just go direct to reports and see what was going on within their data and performance. Also, the system provides them like defaulters report with evidence information, like where the children are, and it's easy for them to trace. So what we have learned, the tools itself really helps healthcare workers to use their data, and this has really shown the evidence to most of the facilities, because it simplifies their work comparing to paper tools where they have to take like 3 to 4 tools and then triangulate data and then see where is it. But if they have one tool which can help them to triangulate their data and provide reports, then it's easy for them to use that data for decision making, for follow-up, to improve performance. So that is what I wanted to share with you. But another thing that I wanted to share is most of the healthcare workers are really using their data, but one thing that we are missing is how to document, how to document those evidences so that others can learn from the facilities or from the regional district that are using data. So I wanted, maybe this is like a question from you, how do we support or facilitate most of the healthcare workers who are using data to be able to document or to share experiences based on what they have done? Thank you.
Yes, thanks, Dinus, and we are very much aware of BID in Tanzania and Zambia. I think I have also some resources that I can even put in the resource box for everybody to know and share. On your specific question, I saw Carolina engaged. Do you want to ask, or do you want to?
Go ahead, because we are running out of time.
But I think, Dinus, your specific question was also like, how can we make sure that people can share their work with other people? Is it about the scale up and kind of peer-to-peer learning? Is that what you want to ask or suggest? Yeah, so maybe we're probably running out of time, but yes, so I think the risk or one of the side effects of having like a complex implementation like an electronic immunization registry in Tanzania and Zambia is that there will be a lot of lessons learned and people will really kind of like have a new way of engaging with data, and there's a lot of interesting things that can be learned and shared. The problem now is how do you organize for that? And I understand that because even if at the global level we have like difficulties getting our act together on kind of sharing good experiences, like at a national level in the country it becomes a little more difficult. What I would say is kind of these things like informal networks and even using kind of WhatsApp groups and whatnot can really work a lot. And then I would also say like, but I would try to, instead of doing train the trainer, I would try to kind of go to a model where you have kind of like learning from peers, like people, basically nurses or health workers who are really good with that system, have a chance to actually go to other districts and teach other people, not just on how the system works, but what their best tricks and tips are for them.
And also share the experiences and be there to answer questions. I think it's really important to have the trust in somebody who can answer your questions. I would say enroll all in TechNet 21. Hopefully we can use it as a platform for all countries. But keep trying in your countries with WhatsApp, with other tools you may have there. Thank you.
I think we came a bit to the end of the time that was allotted, so it always goes fast, it's 1 hour and a half. I just want to say, like, if you have the agenda or the calendar for the webinars on the calendar, it's that next week there would be a webinar on denominators, so that's actually going to be changed by this webinar on HMIS with a focus on DHIS2. That is basically because of the key people we need for denominators and geographical information systems are not available next week, and we would like them to be involved, our UNICEF colleagues most. Next week, so we will talk about HMIS with a focus on DHIS2, and whether your country has a national HMIS and the collaboration between HMIS and EPI is a bit difficult, or it is just being planned, or you only have an HMIS but it doesn't quite work for EPI. So we want to have a webinar that talks about all the standard modules that were developed around DHIS2 to actually implement immunization programs better. So we'll tell you a bit about the state of the art, and we'll also even tell about how DHIS2 is now developing modules for surveillance and vaccination registries, so the tracker module. As well as kind of specific dashboards for immunization. And while we were talking, I think where we can all tie together, like I think the dashboards, even if they were like the lowest priority maybe, could also be a really good place where we could start seeing some of that triangulation just by putting the right data next to each other, with each other together, so that we can really start reinforcing that use of data. So next week that will be with Karine Gatchen from Gavi. So thanks again for joining, and it was great. I don't know if you guys want to say some last words to the participants. For me, this is always very energizing, and I'm always very happy to have so many people.
I'll say that it was a pleasure to be here with you. The slides will be shared. There is a recording as well, so share your practices and tell us how you're doing. Thank you.
And this was my my first time joining, so it was really exciting for me. I've heard a lot about this course and how successful it's been. So thanks so much to all of you guys who are trying so hard out in the field, and thanks for having me. It's been a pleasure.
Thank you.
Thank you, everyone. Thank you, everybody. I hope that the scholars doing their week 2 assignment will have a better use of the webinar for today to improve their work and their project. Thank you for newcomers. Thank you for all of you. Thank you, WHO, CDC. It was amazing to be here. We are running out of time. Thank you for according us the 4-minute extra. We were really happy to have you, to hear from you, from your experience. And then we would like to see you next Wednesday, 16th of October at the same time for HMIS. That will be another fantastic experience with you. Thank you and bye. See you next week.